disease. Chronic kidney disease is abnormal kidney function for more than 3 months with progressive decline in GFR. This is the staging of chronic kidney disease, which is done on the basis of GFR and albuminuria. Based on GFR, it is divided from G1 to G5. G1 is more than 90 ml per minute per 1.73 meter square. G2 is 60 to 89. G3 is again divided into G3A and G3B. G3A is 45 to 59. G3B is 30 to 44. G4 is 15 to 29. And G5, which is called as the end-stage renal disease, that is less than 15. And this is again divided based on albuminuria into A1, A2 and A3. A1 is less than 30 mg albumin per gram of creatinine. A2 is 30 to 300. A3 is more than 300. The color coding shows the severity of the stage. So end-stage renal disease is stage 5 CKD. It is that stage of renal disease where there is so much accumulation of toxins, fluids and electrolytes that unless it is removed by a renal replacement therapy in the form of dialysis or kidney transplantation, it may lead to death of the patient. So what happens in CKD is there is an initiating mechanism which is different in different causes. Like for example, in exposure to any toxin, or in case of glomerulonephritis, immune complex deposition or inflammation. Okay, so when there is an initiating mechanism, it destroys the nephrons. So what happens, the remaining good viable nephrons, they will try to compensate for it by undergoing hypertrophy and hyperfiltration. When there is so much hyperfiltration, there is excessive pressure inside the nephron. That leads to destruction of the filtration barrier. This leads to sclerosis and dropout of the remaining nephrons. So this keeps continuing and slowly there is decline in the renal function. This is the pathophysiology of CKD. So there are certain risk factors associated with CKD like hypertension, diabetes, advanced age, family history of kidney disease, previous episodes of AKI, African ancestry, autoimmune diseases, childhood obesity, small for gestational birth weight, proteinuria, structural abnormalities of the urinary tract, or the presence of APOL1 gene. In case of this, any environmental trigger like a viral infection can transform the genetic risk into a disease. So the most common causes of CKD are diabetes, hypertension, glomerulonephritis, ADPKD, other cystic and tubulointerstitial nephropathies. So the GFR is usually lower in women as compared to men, and there is an annual decline in GFR starting from the third decade. So what happens, the peak GFR of 120 is achieved around the third decade of life, and after that slowly every year there is reduction in GFR by 1 ml. So that at the age of 70, GFR reaches around 70 ml per minute per 1.73 meters square. So because of this annual decline, if you look at the GFR of many elderly patients, it may be compatible with the GFR level of stage 2 or 3 CKD. So in these patients, if we keep rechecking the GFR, we have to see if there is any decline in GFR or if there is any albuminuria, then we have to refer to the nephrologist. So to estimate GFR, we can use MDRD equation or CKD EPI equation. And this kidney failure risk equation is used to predict the risk of progression to stage 5 CKD. This uses the age, sex, region, that is whether North American or not, GFR and urine albumin creatinine ratio. The risk of progression is greater in North Americans. So majority of these CKD patients, before they reach the advanced stage of CKD, they succumb to cardiovascular and cerebrovascular complications. So there are various manifestations of CKD and uremia in the form of fluid and electrolyte and acid-base disorders, disorders of calcium and phosphate metabolism, cardiovascular abnormalities, hematologic abnormalities, neuromuscular abnormalities, GI and nutritional abnormalities, endocrine abnormalities, metabolic disturbances, and dermatologic abnormalities. We'll look into each of this. So in fluid, electrolyte, and acid-base disorders, there is sodium retention, fluid retention leading to hypertension. So what we can do for this? Salt restriction, loop diuretics, and if it is not working, then we can add metolazone, which is a thiazide-like diuretic. And if still there is diuretic resistance with intractable advanced hypertension, we can go for dialysis. Water restriction is only indicated if there is hyponatremia. And in CKD, there may be hyperkalemia. So if there's hyperkalemia, what we can do is potassium restriction, avoiding potassium supplements, caluritic diuretics, and potassium binding agents like calcium resonium, sodium polystyrene, and patiromer. If there is intractable hyperkalemia, then again it's an indication for diuresis. And in the earlier stages of CKD, there is non-anionic gap metabolic acidosis. But as the CKD progresses, it will lead to anion gap metabolic acidosis. Metabolic acidosis is associated with protein catabolism. So to prevent this protein catabolism, we have to treat the metabolic acidosis with sodium bicarbonate. And we give sodium bicarbonate if the serum bicarbonate level is below 20 to 23 millimole per liter. So in disorders of calcium and phosphate metabolism, they can be either high parathormone levels or low parathormone levels. Usually there are high parathormone levels and that leads to high bone turnover, leading to osteitis fibrosa cystica. If there are low parathormone levels, it leads to low bone turnover and leads to low mineralization of the bone, leading to adynamic bone disease. And since kidneys are responsible for the secreting this 1-alpha hydroxylase leading to formation of calcitriol, in CKD there is low calcitriol and that leads to osteomalacia. And there is this condition called calciphylaxis which can occur in advanced CKD. Here there is extensive calcium deposition in the vessels and the soft tissues. And when it is deposited into the vessels, it may lead to vascular occlusion. This may occur because of excessive calcium in the form of calcium-containing phosphate binders. And warfarin is also a risk factor for calciphylaxis. So what we can do for this? Parathormone, actually what happens in CKD, the kidney is not able to excrete excrete phosphorus. So because of excessive phosphorus retention, it leads to stimulation of parathormone secretion. There is parathormone secretion and that leads to high parathormone levels. So if we want to reduce the parathormone levels, we have to reduce the phosphorus. So that's why we can give low phosphate diet, phosphate binding agents like calcium acetate and calcium carbonate. But if we are giving this calcium acetate and calcium carbonate, there is a risk for hypercalcemia. So to prevent that, we can give non-calcium containing phosphate binding agents like sevelamer and lanthanum. And calcitriol can also suppress parathormone, but calcitriol has a risk of causing hypercalcemia and hypophosphatemia through excessive GI absorption. But calcitriol analogs like paricalcitol will suppress the parathormone with less attendant hypercalcemia. So we can use calcitriol analogs like paricalcitol. And calcium mimetics like cinacalcet, what they'll do, they'll increase the sensitivity of the parathyroid gland to the existing calcium in the blood. So there will be less production of parathormone. And we have to target a parathormone level between 150 to 300 picogram per ml, because even if it becomes low, there is a chance for having adynamic bone disease. So it should be between 150 to 300. Cardiovascular abnormalities include hypertension, left ventricular hypertrophy, heart failure, ischemic vascular disease, and pericardial disease. So this hypertension and left ventricular hypertrophy is because of this thing. When there is chronic fluid overload, it will lead to hypertension. And this exogenous erythropoietin stimulating agents that we give, they also have a tendency to increase the blood pressure. So because of that, there will be hypertension. This hypertension may lead to left ventricular hypertrophy. So we have to target a BP which is less than 130 by 80 mmHg and give AC inhibitors or ARBs because they slow the progression of CKD. Heart failure in CKD occurs by various mechanisms. First thing, when there is salt and water retention, there will be hypertension that may lead to left ventricular hypertrophy, leading to diastolic dysfunction, leading to heart failure and pulmonary edema. And in case of advanced CKD, there is so much uremia, and this leads to increased permeability of alveolar capillary membranes, leading to a low pressure pulmonary edema. Also, the anemia which happens in CKD can contribute to heart failure. Ischemic vascular disease. The inflammatory state in CKD will accelerate the vascular occlusive disease. And also when the patient undergoes hemodialysis, there is a chance of having episodes of hypertension and hypovolemia, and that may lead to coronary ischemia. That is why in CKD patients, cardiac troponin levels are frequently elevated. So what we have to do is we have to observe the trend in the levels over hours instead of looking at a single troponin level. Pericardial disease. In case of advanced uremia, there can be pericarditis, and that pericarditis can lead to pericardial effusion and rarely tamponade. So uremic pericarditis is an absolute indication for initiation of dialysis. And if there is recurrent pericardial effusion or echocardiographic signs of tamponade, then we have to do pericardial drainage procedure. Hematological abnormalities include anemia and abnormal hemostasis. Anemia of CKD is normocytic, normochromic. It occurs as early as stage 3 CKD and it is almost universal by stage 4. The primary cause of it is insufficient production of EPO. But there are various other causes of anemia in CKD like relative deficiency of erythropoietin, chronic inflammation, iron folate or vitamin B12 deficiency, diminished red blood cell survival, bleeding diathesis, hemoglobinopathy, hyperparathyroidism or bone marrow fibrosis. So what we can do for this is give erythropoiesis stimulating agents. And along with that, we have to give iron supplementation because this erythropoiesis stimulating agent may not work without iron. So we have to ensure give iron supplementation and ensure adequate supply of B12 and folate. So this iron, if the patient is on hemodialysis, we can give IV iron during dialysis. But if the patient is not yet on dialysis or if the patient is on peritoneal dialysis, we have to attempt giving oral iron and see if there is any GI intolerance. Then we have to give IV iron. Okay. Then in this ESA that we are giving in CKD, this increases the risk of stroke as well as thromboembolic events, and it may even lead to a faster progression of CKD. And also complete normalization of hemoglobin is not beneficial in CKD. So that is why we keep a target hemoglobin of 10 to 11.5 gram per deciliter in CKD patients. Abnormal hemostasis is seen in CKD linked to prolonged bleeding time. But in CKD, there is also susceptibility to thromboembolism. So there can be either prolonged bleeding or thromboembolism. This thromboembolism susceptibility is seen especially if there is nephrotic range proteinuria. So for the prolonged bleeding time, we can give desmopressin, cryoprecipitate, IV conjugated estrogens, blood transfusion, ESA therapy, dialysis, and use unfractionated heparin by titrating it to APTT and to avoid or adjust the dose of fractionated low molecular weight heparin. The neuromuscular abnormalities include disturbances in concentration, memory, and sleep. There may be neuromuscular irritability, which may manifest in the form of hiccups, cramps, and twitching. In advanced CKD, there is asterixis, seizures, and coma. There can be peripheral neuropathy and restless leg syndrome. This peripheral neuropathy, which occurs in CKD when there is no other cause like diabetes mellitus, then it is an indication to start dialysis. GI abnormalities and nutritional abnormalities. Uremic fever, that is a urine-like odor of the breath. And dysgeusia, that is unpleasant metallic taste. There can be gastritis with mucosal ulcerations leading to pain in abdomen, nausea, vomiting, GI bleeding and all. And these patients, they are prone to constipation, and this is worsened by the calcium and iron supplements. So what we can do to reduce this nausea and vomiting is we can restrict protein intake. But when we restrict protein intake, there is a risk for malnutrition. When there is weight loss or malnutrition, it is an indication to initiate dialysis. Endocrine metabolic disturbances. Since kidney is important for the removal of clearance of insulin from the blood, the plasma levels of insulin will be elevated in CKD patients. And we need to reduce the dose of gliptins in CKD patients. And in case of metformin, we should not start it if the GFR is less than 45. And if the patient is already on metformin, then we have to stop it once the GFR is less than 30. In case of women, in CKD, there is low estrogen level, menstrual abnormalities, infertility, spontaneous abortion, and pregnancy can hasten the progression of CKD. In men, there is low testosterone level, sexual dysfunction, oligospermia. In adolescents, there may be delayed sexual maturation. Dermatologic abnormalities include pruritus, pigmentation. So for this, we can give moisturizers, topical glucocorticoids, oral antihistamines, UV radiation. And rarely, in case of CKD patients who are exposed to gadolinium, there can be nephrogenic fibrosing dermopathy. This is rare. In this condition, there is progressive subcutaneous induration, especially on arms and legs. So investigations, first we should make sure that it is chronic by doing, instead of we have to differentiate it from an acute kidney injury by doing serial measurements of renal function, and check hemoglobin, iron, B12 and folate levels, 24-hour urine collection to look for proteinuria, serum calcium, phosphorus, vitamin D and parathormone to evaluate for metabolic bone disease, and do an ultrasound. If on ultrasound we find bilaterally small kidneys, it supports the diagnosis of CKD. But there are few exceptions like diabetic nephropathy, in which the size is increased at the onset of the disease. In case of amyloidosis and HIV nephropathy, the size of kidneys is normal. And in case of polycystic kidney disease, there will be enlarged kidneys with multiple cysts. If the difference between both the kidney lengths is more than 1 centimeter, it suggests an unilateral abnormality. Kidney biopsy is not indicated in every patient of CKD, and especially if the patient has bilaterally small kidneys, then renal biopsy is not advised, because first thing, it is technically difficult, we lead to bleeding, and there's already so much scarring in the bilaterally small kidneys that the underlying disease may not be apparent. And even if it is apparent, the window of opportunity to do something, to give some disease specific therapy, it has already passed. And there are other contraindications to renal biopsy like uncontrolled hypertension, active UTI, bleeding diathesis, and severe obesity. So to slow the progression of CKD, we have to control the blood pressure, because when there is elevated blood pressure, it will increase the proteinuria. So for that, we have to give AC inhibitors and ARBs. These AC inhibitors and ARBs, they slow the progression of renal failure. But if there is no antiproteinuric response with either of it alone, then we can combine both AC inhibitors and ARBs. And try to avoid all nephrotoxic drugs, and do not give IV or intraarterial dye whenever possible. And if it is unavoidable to give contrast, then at the time of contrast exposure, we have to avoid hypoglycemia and use a contrast with least nephrotoxic potential, and give sodium bicarbonate containing solutions at N-acetyl cysteine. In case of stage 3, we have to minimize the exposure to gadolinium. In case of stages 4 and 5, we have to avoid gadolinium unless medically necessary. But if it is being given, then we have to make sure that immediately after the procedure, we remove the gadolinium with hemodialysis. So there are various indications for the initiation of renal replacement therapy like uremic pericarditis, encephalopathy, intractable muscle cramping, anorexia and nausea which is not due to any other cause, malnutrition, fluid and electrolyte abnormalities, especially hyperkalemia, and extracellular fluid volume overload which is refractory to other measures. So kidney transplantation is the best for complete rehabilitation, because dialysis, although it replaces many functions of the kidneys, it does not replace the endocrine and anti-inflammatory function of kidney. So although it's usually like we do kidney transplantation after a period of dialysis, if we know for sure that this renal failure is irreversible, then directly we can go for kidney transplantation. Thank you.